on risk communication and pandemic preparedness communication. So we're very excited. There's a lot of science that we'll get to talk about this morning, and we only have 2.5 hours to do all of this. And so with no further ado, we should move on.
So do you want to introduce?
Okay. And so I will introduce our first speaker, Dr. Vernon Lee, who is from Singapore. He's the Group Director of the Communicable Diseases Division, Singapore Ministry Department of Health. He's the Executive Director of the National Center for Infectious Diseases, the Interim Communicable Diseases Agency in Singapore. He has his degrees in PhD in epidemiology from Australian National University, MPH and MBA from Johns Hopkins in the USA. He was instrumental in implementing, developing, and carrying out the COVID-19 vaccine response in Singapore that, as everybody knows, was highly successful. And so he will present on video. So why don't we go ahead and enjoy Dr. Vernon Lee's presentation.
Very good day to everyone. I'm Vernon Lee from the Ministry of Health Singapore, and today I'll be talking about the policy to address vaccine hesitancy in both influenza and COVID-19 vaccination programs using examples from my experience here in Singapore. Today's presentation will talk a little bit about Singapore's vaccination program, how we approach our life course multi-pronged vaccination policies, and also our current recommendations for flu and COVID-19 vaccines. Then I'll talk about our strategies to address vaccine hesitancy, including dealing with safety and efficacy of vaccines, providing clear vaccine recommendations, increasing public awareness on vaccinations, and also enhancing accessibility and affordability of vaccination. First, on Singapore's vaccination program. Singapore uses a life course multi-pronged approach to vaccination, and this is the cornerstone of our strategy to provide vaccines for people from all walks of life across all ages. First, we have a legislation, which is our Infectious Diseases Act, which mandates measles and diphtheria vaccinations. And together with measles and diphtheria, because they usually come in a package with MMR and Tdap or DPT vaccines, you can see that quite a number of vaccines are covered by this approach. In addition, new vaccines that are available in the market have to be approved by our regulators, the Health Sciences Authority, and they would do a very thorough evaluation on the effectiveness and safety of these vaccines, and also provide surveillance for vaccine adverse events. And once the vaccine is registered, they can then be used in Singapore. Vaccines that are available for use are then put through an expert committee for immunization, an independent group of experts formed by clinicians, scientists, and so on, and they provide the ministry with recommendations on which vaccines we should put on both our national childhood immunization schedule and also our national adult immunization schedule. Vaccines that are put onto these schedules also have to meet a cost effectiveness bar to show that they are both clinical and cost effective for use in the population. Subsequently, once vaccines are placed onto these schedules, and for other vaccines that are also recommended, we will look at how do we roll out these vaccines, whether it be through our primary care networks, our school-based vaccination systems, or through other networks as well. Finally, are all the enablers such as financing schemes, the availability of vaccine records so that individuals can actually see what vaccines they have obtained, public communications, and other touch points to ensure that vaccines are made readily available, accessible, and um, and education is provided to the population on what are the best vaccines that are available and recommended for them. In terms of influenza vaccines, these are the current recommendations for our schedules. Under our current national immunization schedules, we do recommend that adults age 65 and above, young children age 6 months to under 5 years, and also adults and children with comorbid medical conditions, they should receive the flu vaccine to prevent influenza-related complications or severe disease. In addition, we also recommend additional groups to receive the flu vaccine to reduce risk of transmission, including healthcare workers and staff in healthcare institutions, persons living, working in closed environments, staff in early childhood development centers. So these are individuals who work with young children, and also persons who come into contact with poultry, given the risk from avian influenza. Other persons in the population are also strongly encouraged to be vaccinated against influenza, because influenza does spread in the population. In Singapore, given that we are a tropical country, we do have a very high baseline of influenza and respiratory virus circulation throughout the year, with sometimes 1 or 2 epidemic peaks a year. As you can see, because of these recommendations and also the push to get the recommended groups to be vaccinated, the vaccination uptake rates have been increasing across the years. For those who are above 65, the vaccination rates over the past few years have been increasing by quite a good percentage. And this can be attributed to many of the initiatives that I'll talk about later. COVID-19 vaccinations, currently, we recommend that all individuals aged 6 and above who have not been vaccinated against COVID-19 to receive at least 2 initial vaccine doses at an interval of 8 weeks apart. An additional dose of an updated vaccine for the year is also recommended to be administered at around 1 year after the last dose is received. Individuals and also residents of aged care and elderly facilities. We also encourage for all persons, for example, those working in healthcare institutions and household members and caregivers of vulnerable individuals to also get the additional dose of the updated vaccine. And this is to be able to protect them against the latest strains of COVID that are in circulation. Thus far, over the past few years, during and after the COVID pandemic, Singapore has experienced about 2 COVID waves a year, and therefore being updated with vaccine doses is important to prevent complications, especially for those who are more vulnerable to infection and severe complications. And as of the end of last year, in fact, more than 88% of the entire population have completed their initial vaccine doses. We know vaccine hesitancy is an issue, not just in Singapore, but globally. And in fact, vaccine hesitancy is not a homogeneous problem. It's actually a very complicated issue with many different factors leading to vaccine hesitancy, including the lack of information, fear of the vaccine and its side effects, and also misinformation, which abound, especially with the advent of social media and the ease at which these misinformations can be promulgated throughout the population. So when we look at developing a strategy to combat and to address vaccine hesitancy, we actually have to address all of these individual components in this very heterogeneous and complex issue. One of the things that we do in trying to understand what are the factors leading to vaccine hesitancy in the population is to conduct surveys and to understand what do different subpopulations, whether it's the elderly, parents of young children, or the general adult working population, what are the reasons that they have that leads towards them being hesitant in getting these vaccines. And once we understand these, we are then able to better target our interventions to address these issues. Some of the strategies that we have been using across the years to address vaccine hesitancy includes ensuring that all of the vaccines that we roll out in the general population are safe and efficacious. There are various legislations, as I mentioned before, that govern vaccine registration under the Health Sciences Authority. They have a Health Products Regulations Act that ensures that any vaccine that is brought into Singapore has to undergo stringent evaluation before it can be registered. There's also transparent reporting and publicly available information on all adverse safety events and side effects of the vaccine. And this is also done by the Health Sciences Authority. This gives the public confidence that the vaccines that we bring in are as safe and as efficacious as possible, and that we are constantly monitoring any of these side effects. We also have relevant expert committees, such as the aforementioned Expert Committee for Immunization, to review the safety and efficacy of the vaccines as well. Is to provide clear vaccine recommendations. This is where we have committees such as the Expert Committee for Immunization to provide clear clinical guidance on the recommended usage and also for the vaccines that should be placed onto our national immunization schedules. In addition to the Expert Committee recommendations, as mentioned earlier, vaccines that are put on our national immunization schedules will also have to undergo a test to show that they are cost effective. So those models will be done so that we are certain that the vaccines are both clinically and cost effective for use in the entire population. And these schedules are our standard of care for protection against vaccine preventable diseases. In addition to the recommended schedules, also other vaccines which professionals would and the government would recommend, for example, sector level vaccination recommendations for persons at higher risk of infection because of the nature of their work in certain industries, for example, the healthcare sector, or in living environments such as the closed living environments in, for example, dormitories. In addition to that, we also provide recommendations for vaccines for use in the general population or even for travel, because there are many different activities that individuals participate in nowadays, especially with the advent of travel and trade all across the world, that may expose individuals to different types of infectious diseases. Is to increase public awareness on vaccines and to address misinformation. Because it is one thing to have a very good system to bring in safe and efficacious vaccines and to develop vaccine recommendations, is another to communicate these very clearly with the general population. Misinformation, as I mentioned earlier, is spreading because of the advent of social media. It is very easy to formulate some half-truths or even untruths and to spread that to the population by various means, whether it be through different social media channels or even through the publication of scientific literature that may mislead the public. So how do we combat misinformation? Actually, the best way of combating misinformation is actually to release a lot of good information through various channels. And this we do via the government, via various media campaigns, and also through individuals or influencers who can actually help us to put out a lot of good information, to flood all these channels with the correct information so that people can see that this correct information is actually out there and they'll not be misled by a lot of the misinformation that abounds. So, for example, public education campaigns, posts on social media channels, dissemination of letters to the media, even publication of scientific articles, and message reminders through government message platforms to individuals to let them know about why they need to get the vaccines. We are not saying that vaccines are, how do you put it? What we're trying to put out, in fact, is that vaccines are important because they have a very good ratio. Now, vaccines are not without risk, and that's why we are very transparent about it. What we're trying to say is that when you get vaccinated, the benefits that you will have for yourself and for the people around you far outweigh the risk. And that's why it is very important to get vaccinated to protect yourself. And we have enough evidence to show that COVID-19 and also flu vaccines protect high-risk individuals from severe outcomes of those disease. For example, at the bottom, you can see that we have targeted mass media campaigns using some of the celebrities that are very visible and very known among the population. And on the right, you can see that our Minister for Health and our Prime Minister have also put out social media posts to show that they have received vaccines and encourage the population to get vaccinated in that manner. Also put out access to personal vaccination records through a digital health platform that provides one-stop access to all of Singaporeans' personal medical records. And this also links them to healthcare services, institutions, and other health information, including all of their consults, blood tests, for example, and also vaccinations that they have received. This helps them to understand what vaccines they have received across time, what vaccines they may not yet have received, and what vaccines they should receive because, for example, their vaccines are not updated and they will need the vaccination soon. For example, the annual flu vaccine or an updated COVID vaccine if they're of the right recommended group. Also, proactively share our data and scientific observations with the public to reduce mistrust on vaccines. So the Health Sciences Authority, as I mentioned, shares many safety updates publicly to show what are the suspected adverse events that have been reported to us across all the different vaccines that are in use, whether it be COVID vaccines, flu vaccines, or otherwise. In this transparent manner, you can actually see, or the public can actually see, what are the potential adverse events due to the vaccine, but also what are the benefits due to vaccine. And you can see, for example, in the center, the Ministry of Health and also our academic institutions and our scientists in Singapore have published many articles showing the impact that vaccines have had in reducing morbidity and mortality due to COVID-19 and influenza. And we have shown that, in fact, Singapore's low COVID-19 death rates during the COVID-19 have been due to many of the interventions that we have put out, and that excess deaths during this period could be directly accounted to the COVID-19 infection waves that have occurred across the years. So vaccinations, in fact, reduce morbidity and also mortality, as I mentioned, and we have the evidence to back up this this information, because we have the scientific data that we have analyzed across the years. Also, on occasion, attempt to debunk common misinformation regarding vaccinations on social media. For example, if you look at the graphic on the right, you can see that while many in the public might think that vaccines might cause issues such as heart attack and stroke, we actually come out to say that the evidence have shown that in fact the COVID vaccines are safe, and in fact they protect people with medical conditions from getting severe outcomes. So we put out some of this information, not just only in the scientific literature, because scientific literature can sometimes be difficult to digest by the public. We put out in simple to understand social media posts, or also through different platforms and through different influencers and so on, to get them to educate the public on these facts about vaccines. Finally, we also need to tackle the issue about accessibility and affordability. Accessibility to vaccination can be a problem, especially for some individuals that may not be able to afford the vaccines or may not be able to reach those vaccination centers and so on. So we've increased the affordability of vaccinations by including many schemes, including subsidy schemes available to eligible Singaporeans and permanent residents, For example, children who are Singapore citizens enjoy full subsidies for all vaccinations under the National Child Immunization Schedule at our government primary care clinics. And under our Healthier Singapore initiative, a nationwide program that focuses on preventive health, all enrollees are eligible for full subsidies for vaccinations under the National Adult Immunization Program at their enrolled clinics. And COVID-19 vaccination currently still remains free under the National Vaccination Program. And in fact, we have mobile teams that actually go to the houses of the elderly to provide vaccinations right at their doorstep, and this increases the accessibility of vaccinations. Also increasing accessibility by anchoring our vaccinations at our primary care providers so that they can provide opportunistic vaccines at both inpatient and also specialist outpatient clinics. There are ongoing vaccination programs at nursing homes, long-term care facilities, and also vaccination and testing centers for COVID-19 to facilitate vaccination efforts. And I mentioned earlier about the mobile vaccination teams, and all of this provides good accessibility to our vaccination programs. All in all, you can see that what our approach here in Singapore is to actually deal with misinformation and vaccine hesitancy by first providing safe and effective, efficacious vaccines. Secondly, to provide good information to the public on how we choose these vaccines and also on our vaccine recommendations. And finally, to make sure that all of our vaccines are accessible to the public and also affordable to all of them. Thank you so much.
非常感谢汪德利的那个报告。去年其实他已经也是咱们这个 session 的一个。
For your presentation. Last year, he was also the presenter of our session, and in particular, he touched upon the strategy decision making in Singapore, and he gave examples of the influenza and also COVID-19, and he made a very detailed presentation. I hope that we can also learn from his sharing. Besides, he also mentioned that they have a very comprehensive task force made up of multiple disciplines. In China, we also have a relevant committee. We hope that we can make further improvements. The next speaker is Dr. Lance Rodderwild. He is also an old friend of us, and he is also the senior advisor to our national immunization program of the CDC. And Dr. Rodderwild from 2012 through 2017 was the team leader for the expanded program on immunization in the WHO China country office. Prior to working for WHO China, he also served with US CDC, and from 2000 to 2012, he served as a director in the US CDC, and he was also the physician and trained in pediatrics, and he had won a lot of awards in terms of the contribution to public health. For instance, he is a recipient of the National Immunization Program's Phil Home Award, the Association of State and Territorial Health Officials National Excellence in Public Health Award. And also, last year, he won the Chinese Government Friendship Award. And he has a very professional experiences, and he has a very good understanding of China, including China's immunization program. So today, he will mainly talk about the impact of the vaccination of the health workers. Now the floor is yours, Dr. Lance Rodderwild.
So, good morning, and thank you for that really nice introduction. I As Dr. Peng Zhibing said, I work in the immunization program at China CDC. I love working in the immunization program. It gives me an opportunity to work with really wonderful scientists like my co-moderator, Dr. Peng Zhibing. And so my topic today will be potential impact of healthcare workers for influenza vaccination. Is something that is sort of near and dear to all of our hearts, I think. So just to put things in a little bit of perspective and remind people, WHO has an overall global influenza strategy. And the strategy includes high-quality surveillance, looking at the circulating viruses, morbidity and mortality from the viruses, antiviral susceptibility. Very importantly, of course, annual vaccination, which is one of the reasons why we're here, antiviral use when indicated, and research to improve all aspects. So WHO, for recommendations, has always published healthcare worker vaccination recommendations, and the most recent overall recommendation for influenza vaccination comes from in 2022, and this is the first, the same priority target populations: healthcare workers, older people, pregnant women, people with medical conditions, and then children, depending on the national disease goals in here. So these have been consistent, but now for the first time, WHO has kind of an even recommendation for these. But WHO has consistently, over the years, from the very beginning of influenza recommendations, has recommended influenza vaccination of healthcare workers, going all the way back to the first one in 2002, then 2005, 2012, and then the 2022 one that I just showed. So most countries have influenza vaccination recommendations. Over 62 countries target all 5 risk groups, but if you look at risk group by risk groups, healthcare workers are among the most frequently targeted over here. So around 90% of all countries target healthcare workers for their program. China CDC, of course, also prioritizes influenza vaccination of healthcare workers. It's in one of the top groups for people with medical personnel because of their exposure risk. This includes, of course, doctors and medical staff, public health professionals as well, and then certainly during the COVID-19 pandemic, when this was written, quarantine professionals. So healthcare workers are highly recommended to be vaccinated. And so the question is, why? Why are healthcare workers so important? And I think there are several reasons. Healthcare workers and providers are at special risk of influenza. They're a special population. I think this doctor here kind of says it all. She says, I won't spread flu to my patients or my family. And of course, she needs to protect herself as well. So it's pretty well, I think, settled science that healthcare professionals are at greater risk of influenza than other working adults. I think this got, one of the best reviews of this was a systematic review of observational studies from 1950 excuse me, through 2010. These are either observational studies or randomized controlled trials, and the outcomes in these studies were either all infections or symptomatic infections. And you can see over here, whether you were vaccinated or unvaccinated, the healthcare workers' risk of getting influenza was way higher than it was of an equal non-healthcare worker adult. And so it's just a remarkable difference in here. And they concluded that compared to adults working in non-healthcare settings, healthcare workers are at significantly higher risk for influenza. This was also shown during the H1N1 2009 pandemic in a very nice systematic review and meta-analysis of observational studies. There were 15 studies, and they had a lot of subjects, nearly 30,000 subjects, and healthcare workers in this systematic review and in the meta-analysis were twice as likely to get influenza than population or even other hospital-based controls. In other words, even controls who worked at the hospital that were not healthcare workers, the healthcare worker themselves were at higher risk. Now, healthcare workers are very dedicated, and of course, sometimes healthcare workers can be a little bit too dedicated to their work, and sometimes they work while they're ill. There was a nice study conducted in Switzerland. Is a teaching hospital over 2 influenza seasons about 8 or 9 years ago, and they looked at daily symptom and work diaries of 152 healthcare workers. Most were nurses and some were doctors, and the outcomes they looked at were missed work, and 18% of healthcare workers missed work due to a respiratory illness. 70% of healthcare workers reported working while they were symptomatic. So this is a problem. They were a little bit too dedicated to their work. 9% of the working days, healthcare workers had flu symptoms. So sometimes healthcare workers can be a little bit too dedicated, and this is one of the mechanisms for spreading influenza. So there was a marvelous study showing that healthcare workers really can infect patients with influenza virus. And so this was a setting in a hospital geriatric unit. So a geriatric unit is for older patients, and they studied 15 doctors, 32 nurses, and 37 patients. And everyone wore high-resolution location sensors, so they knew within a few inches where they were. And so at the beginning of this observational study, 11 subjects had influenza at the start of the study. And what's shown in the circle here are all the interactions that either patients or nurses or doctors had. And you can see the color shows up. The yellow ones are ones where somebody was infected during their hospital stay. The red ones were people who were infected already. And you can just sort of imagine this swirl of interactions and patients where it's an easy environment to spread influenza. I think this picture is worth looking at for a while because it's just absolutely fascinating. But we don't have time to stare at it for too long. Now, fortunately, influenza vaccination does protect healthcare workers. There are very few placebo-controlled, randomized controlled trials, but there was one conducted in the 90s in the U.S. in a teaching hospital. It was a placebo-controlled, randomized controlled trial over 2 to 3 influenza seasons, and they looked at serologically defined outcomes. They found that the VE, vaccine effectiveness, was very high, around 90%, 88 and 89%. And you can see that compared to the placebo recipients, the vaccine recipients had, about 90% less risk of getting influenza. And interestingly, they missed fewer work days. So in addition to sort of protecting against influenza, flu vaccine also reduces absenteeism at work. This was shown in a nice systematic review and meta-analysis. There were 13 studies, 3 of which were randomized controlled trials. This meta-analysis was quite large. It had around 20,000 subjects in here, and 25% of the subjects were vaccinated. Their outcome was laboratory-proven influenza, and it was reduced by around 60% by vaccination. But the interesting thing is that influenza-related absenteeism or missed work was reduced by about 18% just due to vaccination. So it really helps a hospital, it helps the hospital keep going because you have fewer people actually missing work. So influenza protects the healthcare worker. It helps protect them from being absent at work and missing work. But influenza vaccination also does protect patients. And so this was a nice study conducted in the Netherlands. It was a cluster randomized controlled trial of 6 hospitals. There were 3 intervention hospitals and 3 controls. So not a huge study, but a study randomized controlled trial nonetheless. The intervention was a strategy to encourage influenza vaccination of staff. And the intervention hospitals did have higher coverage. It was around 32 versus 24 in the first year, and 62 versus 38% in the first year. So both groups had some vaccination, but the intervention hospital had higher vaccination. And they looked at outcomes on the pediatric and the adult wards. In the pediatric wards, there wasn't that much transmission, but the adult wards, you could really see either influenza or pneumonia, the huge difference between the intervention hospital that had much lower incidence of pneumonia than did the control hospital shown in the red. So influenza vaccination of staff can help protect the adult patients. Earlier than that, this was nearly, almost 25 years ago, there were a couple of other cluster randomized control trials, and these two were completely independent, but they were very similar. They were long-term care facilities were randomized to either encourage flu vaccination of the staff or just standard of care vaccination of staff. And what they found out is that with about 51% vaccinated in this one and around 61% vaccinated in the other cluster randomized control trial, that there was an impact against mortality. It was reduced about 13% in here, with an odds ratio of dying from anything almost cut in half, around 0.58 or 0.56%. So this is kind of a remarkable study. I think it's a little bit controversial, but you can see most clearly in this KM diagram the vertical distance between the control hospital and the intervention hospital. So vaccination of staff is good. It's good for patients. So one thing that, so several of the people who are leaders in this conference, in this meeting, conducted a really nice study, and they showed that healthcare workers who are confident in their knowledge of influenza vaccine, they're more likely to get a flu vaccine. It was a survey of respiratory physicians in China. It was a large survey, nearly 18,000 subjects, and then 30% were very confident that they knew a lot about influenza. And so if you had low confidence, moderate confidence, or high confidence, you can see there was sort of a dose response in that the higher the confidence in your knowledge of influenza, the more likely you are to get vaccinated. So the more you know, the more you want to get vaccinated. That's always a good thing. So another, kind of a philosophical point on this is, I think that healthcare worker, if they don't accept flu vaccination, or if its lack of acceptance of influenza vaccination is associated with flu vaccine hesitancy. And so the interesting thing is, in red here, what direction is the causation? Are they hesitant because they don't have experience with the vaccine, or do they not get vaccinated because they're hesitant? So these association studies can't really tell the difference in cause and effect. But I think that when healthcare workers get vaccinated, their hesitancy goes down because they realize it's a very easy vaccine. It's hardly reactogenic at all. It's very easy to do. So I think that hesitancy can be overcome by gaining experience with being vaccinated. Now, one thing that was also interesting, healthcare workers were clearly SARS-CoV-2 targeted by the virus. Everybody knows that. It was just a huge impact. But what was nice to see is that experience of healthcare workers after and during the COVID-19 pandemic, they were more likely to also get influenza vaccination. I think there was this realization that the virus is targeting the influenza worker. This was a systematic review and meta-analysis, and they looked at the effect of COVID-19 pandemic on vaccination intent in several countries, and you can see that pre-pandemic in the gray, the vaccination rates were lower, and during pandemic, influenza vaccination rates were higher. So this is good. I think that there's some boosting in confidence and experience from the COVID-19 pandemic that may help with healthcare worker vaccination in the future. Providers who accept influenza vaccine for themselves are more likely to recommend it for their patients. And this has been known for a long, long time. But there was a nice survey of providers here in China, and it was also this huge survey, nearly 18,000. It was an unusual sample. It was sort of a snowball sample where one recipient of the questionnaire can send it to others. So it's not a systematic sample, but 75% were highly accepting of flu vaccine for themselves. 83% said that they will or probably will recommend it for their patients. And so what was interesting is the willingness to recommend to patients had a strong positive correlation with acceptance. And so if they were only moderately accepting, 23% were highly willing to recommend it to their patients. But if they got vaccine, they were almost 3 times more likely to recommend the vaccine to their patients. This is a huge impact, I think. In the U.S., the National Immunization Survey also looks at influenza vaccination of children. And so the parents were asked, did your child's doctor recommend influenza vaccine for you? And if they did, you can see in the red additional bars here how much more likely the child was to get vaccinated against influenza. So these providers, they're very important. They need to protect themselves so that they can help protect others. Now, healthcare workers, they're really a small proportion of all the people who are recommended in target populations. I really like this province by province. Look, the healthcare workers are the blue bars in here, and these are the other target populations in here. So it's a small target population, but very important and very influential target population. WHO has developed guidance for healthcare worker vaccination. Over here is guidance specific to influenza, and in 2022 they added in other vaccines that WHO recommends for all healthcare workers. You know, measles vaccine, hepatitis B, etc. So one thing that's interesting is, my sense is that healthcare workers want to do the right thing. And so by making hospitals report their coverage among healthcare workers, among their staff, just by making them publicly report how many of them were vaccinated, it makes the vaccination rate of the staff go up and up and up. And this is a 4-year comparison where at the beginning there were not very many highly vaccinated hospitals for healthcare worker vaccination. And then they would report what the rates were publicly, and so that everybody could see how this hospital did vaccinating their staff. So then it goes higher, higher, and higher. And so at the end of 4 years, almost all the hospitals had high vaccination rates just by public reporting. It wasn't a mandate, it wasn't a requirement, it was just reporting how the hospital was doing. So it's possible to get good healthcare worker vaccination results. So I just have a few conclusions. One, of course, is that healthcare workers are at a high risk of influenza, and that vaccination protects the healthcare workers from flu. It decreases workdays missed, and it protects patients. Vaccinated healthcare workers are a positive influence on their patients, and knowledgeable healthcare workers are more accepting of vaccination. It's a good thing. The more you know, the more you want it. It's a good thing. So thank you very much. And I also have to remind everybody, of course, don't forget to get your flu shot. It always is a good thing to lead by example. And I'd like to thank 3 master's degree students shown here for their help with the presentation and translation of the slides. And of course, the interpreter here and the AI as well. So thank you very much.
Thank you so much, Dr. Lams. So as you mentioned, China has our own guidelines, and also the healthcare workers are the priorities for these vaccinations, and we improve that the vaccination rate. And you also shared a story is that is why that this kind of the group needs to have this, and also they shared also about the methodologies of the other countries. And the last year we have released one of the guidelines and the wellness published on one of the journal. We called that one of the infectious associations, some of our teamworks are inside, and so we're constantly to increase the ratio for the vaccinations. And now next speaker is Dr. Wang Xiaoming and Professor Wang, and she is an associate professor at the Hangzhou Normal University School of Public Health, and we focus on social science and infectious disease prevention and control, and also that is funded by the prestigious organizations such as the National Science Foundation of China, the Medical Board, and she published a lot of very important academic journals. And another is that in terms of the social risk communication during the public health emergencies has generated attention from the Nature magazine. Now she will help us to share with us the risk communication, risk perception, and behavior responses in China during COVID-19. Welcome.
University. And my topic for today is risk communication, risk perception, and behavioral responses in China during COVID-19. And my report comprises the following 4 sections: introduction, methods, results, and discussion. In December 2019, the novel coronavirus was reported in Wuhan, China, and the government locked down Wuhan on January 23rd, 2020, during Spring Festival, a time where there are typically large population movement. And also the government implemented social distancing policies, including quarantine, isolation, and travel restrictions, to limit the cross-regional population movements and other social distancing measures to decrease the spread of the disease. And we have analyzed the public, because it is a general consensus that risk communication is very essential during the public health emergencies. So we analyzed 3 of the public responses to 3 of the major vaccine crises in China, which include the 2013 hepatitis B vaccine event, and the 2016 Shandong vaccine scandal, and the 2018 Changchun-Changsheng vaccine crisis. And we observed large fluctuation in parental trust and intention toward these vaccines. So as researchers focus on risk communication and public responses, we designed this study after Wuhan lockdown, and we want to to find out more about these dynamics. So risk communication is defined by the World Health Organization as a real-time exchange of information, advice, and opinions between experts or officials and people who faces threats to their survival, health, or economic or social well-being. And risk communication can guide public sentiment and promote adherence to recommended behavior change. A crucial aspect of risk communication lies in its audience. So it is essential to make sure that the information conveyed by the experts and by the government is not only received, but also comprehended accurately and suspectedly, and also understood or utilized effectively by the audience. But this crucial aspect is often overlooked in practice. The rapid advancement of communication technology enables the risk communication information launched by the government to reach the audience through diverse channels. However, these channels could also facilitate the spread of misinformation. So it is crucial to understand how people access, process, and utilize the risk communication messages launched by the government. And previous research have argued that the disparities in social determinants among the general public would cause inequity in health communication messages, accessing, processing, and utilization. And also ethnic minorities across the world were found to have worse health and social outcomes than non-ethnic minority population. And in addition, the shortage of masks and other personal protection materials became a very large issue, especially at the early stage of the COVID-19 pandemic. So our study aims to describe the risk perception and behavioral responses among Chinese adults during the COVID-19 epidemic, and also to assess the association of social demographic factors exposed to risk communication and public risk perception with behavioral adherence to recommended behavior change, and also the vaccine intention when it is available, because at that time the vaccine is still not available. So here's the methods for our study, and it is a large cross-sectional study conducted between March 1st and March 16, 2020. It covered all the 31 provinces in mainland China, and the questionnaire was developed based on previous risk communication studies and several focus groups, and also 2 independent experts reviewed the questionnaire, and the questionnaire also pre-tested with 30 online face-to-face interviews with the potential respondents and with the various age and education groups. And also in each province, a province-specific investigator was responsible to enroll or convenience sample of 100 to 200 families in each province, and with the aim to oversample the ethnic minorities and also residents in Wuhan. Online training was conducted for these investigators, and they were responsible for the quality control, and also we aim to keep a balance of the urban and rural residents so the family were equally represented, and also an adult family member whose birth date is closest to the survey date administration was selected to ensure the randomness in the family, and also a questionnaire link was distributed by the investigator to the respondents. So we covered a variety of variables, which includes the social demographic characters of the respondents, for example, the residence of province and age, sex, level of urbanicity, ethnicity, and education level. And also we targeted on the COVID-19 risk communication factors, which include exposure to preventive information, which was measured using a 6-item scale, and exposure to misinformation, measured on the 4-item scale, and exposure to misinformation correction, and belief in misinformation, also measured using a 4-item scale. And in terms of the supply and use of the personal protection materials, we specifically ask whether the individuals purchase mask and soap during COVID-19 for the COVID-19 prevention. And also in terms of the risk perception, the individuals were asked to assess their personal risk of contracting COVID-19 on a 5-point Likert scale. And also we measured the preventive behavior undertaken by the respondents, and which encompass like practicing social distancing, which was measured using a 10-item scale, and to capture a various aspects of this behavior, and also wearing masks in public and washing hands with soap when returning home, and also the vaccine acceptance. So here's the results. We have collected 5,039 respondents. Actually, it's 5,039 respondents from this number of families, and the urban and rural residents were equally represented. And this study covered people from 28 out of 55 different ethnic minority groups all over China. And we find a large an overwhelming majority of respondents exposed to the preventive information, which includes the updates on COVID-19 epidemic, the interventions to combat COVID-19 conducted by the community and government, the symptom of COVID-19 and how to protect oneself from being infected, and when to seek care if suspected, and what to do if a family member contracts COVID-19. Approximately 87% of the respondents had received all of this kind of preventive information. And in terms of exposure to misinformation, we find that a large majority of respondents have heard that shuanghuanglian oral liquid, which is a Chinese patent medicine, and hard liquor, which is Chinese baijiu, could prevent COVID-19. And also half of the respondents were exposed to the false claim that COVID-19 is a man-made virus, and also smoking could prevent COVID-19. However, very few of them believe this misinformation to be true. And in terms of the adherence to preventive behavior, we can see that almost everyone that we have reached adherence, very good adherence to the recommended social distancing behaviors, which include the direct avoidance, for example, avoid contact with people suspected to have COVID-19 and who was contacted with suspected COVID-19 patients, and also public space avoidance, which is people avoid spaces like markets and public transport, and also the crowded areas, and also social interaction avoidance. People avoid to visit extended family members and neighbors or friends, and they prefer to stay at home more than usual. And 98% of people reported that they have reduced physical interaction with others. And 93% of people reported that they always wearing a mask when going outside. And 82 reported that they always wash hands when returning back home. And we could say that 87% of people reported that they would accept the COVID-19 vaccine when it is available. And 49% of individuals perceive themselves high or very high to contracting the COVID-19. And we could see social demographic factors positively associated with the risk communication factors and personal protection. For example, people from the rural residents and ethnic minority reported less exposure to the misinformation correction. On the contrary, people with the higher education level and higher household income reported a more exposure to the preventive information and misinformation correction, and a less proportion to believe in the misinformation. Also, the inadequate supply of soap and masks were more prevalent among rural and ethnic minority and people with lower incomes. And risk mitigation factors is associated with people's preventive behaviors. For example, people who reported to exposed to all the preventive information and exposed to the misinformation correction were more likely to conduct all of the recommended behaviors. But people who believe in the misinformation were less likely to wear a mask when in public. And people with a higher risk perception were more likely to engage in all social distancing practices and a higher vaccine acceptance. In terms of risk perception, we find that people from the province which have a higher confirmed patients, and people who with older age, who are female, and ethnic minority, belong to an ethnic minority group and have believed in any of the misinformation, reported to have a higher risk perception. And in terms of the behaviors after controlling for social demographic factors, we find that people who reported preventive, exposed to all the preventive informations have a better adherence to the recommended social distancing behaviors. And people who exposed to misinformation correction had a higher vaccine acceptance than their counterparts and always wearing a mask when in public. And also people who believe in any of the misinformation were less likely to wear a mask when in public. And people, the vaccine acceptance was higher among people who have a high or very high risk perception. And people with the higher risk perception were more likely to engage in all the social distancing practices. And people who reported inadequate of soap and mask supply were less likely to conduct the corresponding behavior. So in conclusion, we find a very high prevalence of Chinese people exposed to risk communication information, and the overwhelming majority of respondents reported to engage in preventive behaviors, and a positive association between the risk communication information exposure and the behaviors. So our study suggested a very positive and effective risk communication strategies conducted by the Chinese government at the early stage of COVID-19 pandemic, which includes the misinformation to release timely information and stem COVID-19 misinformation. And secondly, we find half of respondents reported holding a high risk perception of themselves contracting COVID-19 during the epidemic. Although people who have a high risk perception were more likely to adopt a preventive behavior. In another study of ours, we find that people with high risk perception were more prone to report a higher stress level. So it is better to maintain the effective communication between authorities and the general public, may be an effective way to lessen stress by enhancing safety and reducing excessive risk communication among the public. And also in terms of the inequity issue, we find that people who were male in an older age group and minorities with low education and lower income and living in rural areas showed lower exposure to the risk communication messages. So future communication strategies should target this group of people. That's all the related research that I have presented today. So that's all for my presentation. Thank you for your attention.
What a presentation. That was fabulous. It was such a nice, scientifically done, very timely study. And what I thought was interesting, it was internally consistent. You could see the factors that you might expect to relate to each other, relating to each other. But also, I think this was done before the vaccine was out, as I recall. And your prediction of the vaccination was spot on target, where nicely enough, some of the 10% who were uncertain decided to get vaccinated because coverage became very high. So this was quite a nicely done, wonderfully done survey and a great presentation. Thank you. So our next presenter is Professor Wang Jian, and he's a professor of health economics at Dongfurong Economic and Social Development School at Wuhan University. He has done many consultancies with the World Bank, with the European Union, with DFID of the UK, with UNICEF, with China, and with Myanmar. He's had grants from several funding agencies, including the National Natural Science Foundation, the Ministry of Science and Technology, and the Research Council of Norway. His talk will be on big data technology and pandemic control communication. So let us welcome Professor Wang.
Distinguished Professor Tong and Dr. Lance Roosevelt. First of all, I want to thank World Influenza Conference for this good opportunity. I'm so sorry that I'm on a business trip and I'm not able to attend the meeting in person. According to the requirement of the conference, my topic is Big Data Technology for Epidemic Prevention and Control in China. This presentation is related to the research partnered with our partners in Brazil. This is just a part of our big program, and some of the content is from some published articles of our previous study, and there are several parts in my presentation. Firstly, by using the intelligence, we can do some literature review, and we found that according to the frequency of the words, the more visible or the bigger the word and the highly frequent it is. So you can see that big data, these two words, are the most frequently repeated words, while for the rest of them, we can find some other keywords like storage, technologies, etc. These are also very frequent words. As for database, complex information, and some other relevant words are also quite frequent. If we put all of them in one map, you can see that big data is not only related to tools or storage, but also to applications. So for the implementation, application of big data, we can see its great potential. Big data, simply speaking, the healthcare big data, it mainly covers the full life cycle of human beings. And it mainly include personal health and also medical care services, disease prevention and control, health guarantee, food safety, fitness, etc. And it's an aggregate and also the clustering of the different categories of data. By using healthcare big data, we can enhance precision of diagnosis. We are not only able to improve the model of the healthcare services and disease prevention, and also can play a very important role in economic and social development to strategic resources. First of all, let's have a look at the data source, mainly in 4 categories. The first one is called healthcare big data, or medical care health data, which mainly refers to the data from the electronic personal record, the medical care image data, and the hospitalization record, medication record, and the standardization clinical path data. While the health big data mainly comes from the personal health documents, the data of monitoring personal symptoms, personal preferences, recovery medical care data, and also the health knowledge and data. And the third category is mainly about the biological big data, the data from the different genomics. And also there is another category, which is the big data of operation, mainly referred to the data of cost settlement, the drugs, consumables, medical devices procurement and management, the treatment cost, and the reimbursement data of different diseases, drug research and data, consumer consumption behavior, etc. And there are different sources of data, such as from the hospitals, the grassroots medical facilities, social medical insurance centers, commercial insurance institutions, etc. If we talk about the production of the healthcare big data in real life, there are three different categories, including the medical care and big data management, mainly in 4 parts. For instance, IBM is mainly specialized in safety management of medical care services, while some are related to standardized technology, while other players may be specialized in storage. And there are also some data integrators and platforms, and they are all on the production side of the medical care big data. While from the side of data collection, there are also some famous companies such as the different famous hospitals, genetic hospitals, etc. And then from the perspective of data collection infrastructure, there are 2 different categories. Some are specialized in providing traditional medical care solutions, such as Winning Health, etc. And another category is the internet medical care solution providers. And then if we look at the application of big data, it mainly involves clinical decision support, drug research and development, medical payment, health management, and the public health management, etc. And take the public health management example. There are some search companies such as Google, Baidu, etc. While for health management, and there are some companies specialized in disease prevention, chronic disease management, etc. While for medical care payment, and there are some payment technologies, and also for the clinical decision support, there are also some specialized companies. For the health and the medical care big data, in our real life, actually the data we see just the tip of the iceberg. And below the tip of the iceberg, there are multi-dimensional data. For the health big data, for instance, we mainly touch upon the status quo of medical care development, evaluate the health situation, and also analyze the trend of disease burden, etc. And the data mainly comes from the personal record, and also the health insurance data, as well as chronic disease management, and also biological statistic analysis. Actually, this is an interdisciplinary subject which need the cooperation of different specialists like the physicians, IT engineers, the health economics, and government officials, etc. Interdisciplinary team is needed for the study of health and medical care big data. Now, let's have a look at the data system in China, and especially those used for disease surveillance. And China released the 4631 and 2 framework of health information. And so you can see that fundamentally, we aim to put all the relevant health information to one unified platform, and mainly in 3 specific data base. For instance, the demographic information database, the electronic health record database, and the electronic medical record database. These databases are based on 4 platforms, including country-level health information platform, municipal health information platform, provincial health information platforms, and national health information platforms. These health information platforms integrate different categories information, but mainly in 6 aspects, including public health, medical service, medical insurance, drug administration, family planning, and integrated management. So here you can see that in this system, there are also information security system and population health information standard system. So this is a comprehensive framework of our health information. If we look at the development of China's information technology, in particular, big data technology, there are 4 stages. The first one is from 1980 to 2003, and this is the primary stage. And you can see that the information system and also the health information system just started to use computer technology. The second stage is from 2003 to 2009, which was the exploratory stage. And it's mainly related to regional health informatization, while the third stage is for the rapid promotion of the health information system in China. And we mainly established the National Health Information Platform and the database. Since 2016, we entered the innovation stage, where the advanced information technologies were applied in the health and the medical system. And this is a journey of China's health information technology. And during the COVID-19 period, China used big data technology to prevent the disease. So here you can see the COVID-19 prevention and control, which actually upgrade our healthcare service pattern. For China's healthcare services, there are several categories. The first one is an internet hospital. We established the internet hospital mainly to monitor the fever clinics and follow-up visits for common and chronic disease, psychological counseling services, online payment, etc. At this stage, internet hospital can meet the demands for basic medical services and alleviate the shortage of medical resources. The second part is telemedicine. For telemedicine, it is mainly used for remote consultation, remote medical advice and treatment. It helped break regional restrictions and also help improve treatment and accumulated experiences and offer the best therapies. And another one is Internet plus AI diagnosis and treatment, and this is widely used in terms of the application. We have the AI pre-consultation, services, self-assessment of personal health condition, information records, provision, and also during COVID-19, it can be used for CT scans. It has made great accomplishments. It can greatly improve medical service efficiency. Another one is internet telecommunication. The application mainly include remote office systems, distance learning, and teleconferences. As for its achievement, it successfully maintained the order and efficiency of medical work. Another one is Internet Plus convenience services. The applications include WeChat public accounts, the time sharing, outpatient appointment services, 5G, CPI, and video calling equipment in ICU. The achievements are including reduce offline gathering and reduce cross-infection. And these are the application and the achievements of Internet Plus healthcare in COVID-19 by using big data and IT technology. We have successfully upgraded our healthcare system. If we look at the healthcare big data conceptual structure, and we can have a look at its structure chart of prevention and control of COVID-19 with big data technology. There are several parts. The first one is the fundamental layer or the collocation layer, mainly used to collect the data. For instance, the telecommunication operators, internet, electronic medical report, hospital information system, government health information system, and the disease surveillance and early warning system. Smart devices, and some online questionnaires, and McCogley, med complaints, and also appointments online. All these elements are part of collection layers. And it mainly refers to the different scenarios, and then data can come from these different elements, and they are part of the data source part. And also for the data layer, there are some local layer, cloud layer, from the data from the cloud, from the government, and from the consumption side, and also other data. And that's the data layer. When data is consolidated, then we enter another layer, which is the analysis layer. On the analysis layer, there are 4 segments, including descriptive analytics, diagnostic analytics, predictive analytics, and prescriptive analytics. prescriptive analysis includes the online diagnostics of the internet hospital, etc. While on top of it is the application layer. It's mainly used in the whole process of disease prevention and control. It's fair to say that we have already accumulated very rich experiences and had very successful stories. For instance, in tracking, personnel tracking, and also the epidemic surveillance and early warning, as well as the training of the various sources, drug development and screening, medical treatment, resource allocation, and production recovery. Great roles have been played by the application layers. So actually, during the COVID-19, our great success in the prevention and control is closely related to the big data application. Our paper was also released on JAMA. We described the healthcare big data's role in disease prevention and control, including our basic framework. In the interest of time, that's all for my presentation. Thank you so much.
Okay, thank you so much, Mr. Wang Jin. So that is shared with us a lot of the concept of the big data and to use the big data to solve the problems. And also we face a lot of challenges. This is kind of the great concept of the big data and what kind of the tools and how can we use. And during the COVID-19, what kind of the roles of the this big data use. And also we have the pre-equipped the software. So in the future, we will have more software embedded into this. How can we use this? The status that is really a long way to go, and the ground task that performs. So we would expect it to have a more featured report. Now we welcome to the next speaker. There's also a very important topic is vaccines hesitancy. Professor Fu Chuanxi, he is the Deputy Dean at School of the Public Health and Zhejiang Chinese Medical University. And he focuses on the academic review and both. He's published a lot of Chinese and English and journals, and he uses a lot of the statistics and how to do the evaluations to the disease burden. And at the same time, he has a lot of the background of the London. He is also the scholar of the London School of Hygiene and Tropical Medicine, and also the visiting scholar of the Columbia University Myanmar School of Public. Let's warmly welcome Professor Fu. It is really delighted and happy, and thank you for the introduction. Now, the vaccine hesitancy is a long topic, and once we have existence of the human beings, and we will meet the problems of this vaccine hesitancy. Now, today are the experts of the vaccinations, and so from the perspective of history, And vaccinations can be divided into 3 areas. The first is the era of the smallpox. And the second era is after the World War II, especially the representation as the US. They provided a very good vaccines and enter into the 21st century. We entered into the TCM. And I'd like to share with you that from these pictures, that is some of the landmark of this hesitancy, and this is the Neil is one of the very famous, and also he is the fighter for the vaccines and anglers of the UK doctor, and the France are the countries with the problems of this hesitancy. So in the European countries, that the suspicion and the hesitancy, they said that will have connections with this autism. So after vaccination by the kid, and they got the autisms, and so you can see this is some of this influence or negative influence that caused some of the European countries and EU countries to have a great growth of these measles. So also the polio, this kind of the virus has already been transmitted to the different countries due to the reason that the war between the US and Iraq. So you can see that they just fight against all these disease. So the WHO and some to use these polyoms or the vaccines to be used by these different countries. So you can see that one of the countries in China, we also have a lot of history. So take the Anhui, for example, the area of that is the important part of the vaccination in China. So you can see that is a very great smallpox specialists, the formation of this center. So in 2 rivers are they important, but you know that in China it is really important, but it takes a lot of time to share you the story. So it's really complicated. And also another interesting story is that in one of the sculptures that is in Luoyang city. So this is the CDC in Luoyang. So our team, you know that in ancient times, the doctors are the men majority in ancient times. So they can see that we have the evidence. So in the ancient, a lot of the people, they will say a lot of method of urging universal vaccination, but some people, for example, this one is Hong Lianji in Qing dynasty. He said that does not recognize the cognitive concept of the removing fatal poison and preventing smallpox caused by vaccination, and believed that the risk of the vaccination is higher than that of a natural infection of the onset. So this is from his speech. So you can see that the hesitancy of the vaccine in China, I can share with you. You know that a human vaccination is really a bad condition at the time, and this is the detox process. And so in ancient times, we do not have the cold chain. So you can see that a lot of vaccination season constraints. Although a lot of records started from the Qing and the Ming dynasty, started from Kanxi, he said that the lack of the official attention, and he doesn't pay attention to the vaccination of the general public, and also the high expenses of this vaccination. You know that 3 gold, silver can buy one of this vaccine. So in ancient times, we do not have this training or standardized training at that times, because at that time, this kind of the methodologies cannot be transferred to the other people. And at that time, vaccinations, they think that it is the best season for this is in spring. So you can see that a lot of constrained restrictions. So, and then apart from that, a lot of strict contradictions, a lot of requirement. For example, the infant and have very good body conditions. This is a very good they can receive this. So from this is the burden of the disease caused by vaccine hesitation, and this is the Japan's HPV vaccine crisis like to continue contributing to an increase of the cervix cancer. And the right slide is the decrease in MMR vaccination rates due to the hesitancy can have a significant impact on healthcare, public health, and economy. Now, let's get into the second part, is that connotation and measurement, and how can we measure from the WHO. Once you have an immediate attitude between approval or the rejection of the vaccine is delayed or refusal despite of the availability of the vaccination services. And vaccination hesitancy has related to the attitude, and also the other related to the behavior and the prolonged so you can see this is related to the decision and the person whether you will take in this summer or the spring. So this is a kind of the decision making. And this is a decision divided into the different defined and uncertain, and even after you take, you have the suspicion about the efficacy. So for the measurement of the vaccine hesitancy, we have the 1, 2, 3 very simple questions. And another is that to use the parental attitude towards child vaccination survey. And we have 3Cs, 5C, this is kind of model. So PACV are used frequently. This is a highly correlated with the children's vaccinations. And in a global pandemic, you can see we use 3C model, which means the confidence, complacency, and convenience. So in Chinese system, it's different from that of the Western countries. We have the different history, different culture, and in China, we pay attention to this kind of culture. We prefer to the collectivisms rather than individualism. This is one of the characteristics of the Chinese group. So we also made the surveillance of these Chinese guardians. We visited the 5 cities of this. We use VHS, vaccine hesitancy scale. We also use IVH, influenza vaccine specific scale. We have established new systems. It is a Chinese traditionals. We have 8 questions, which include whether the attitudes toward the government, whether to take the vaccination is the responsibility to you, and whether this is kind of 8 questions. So after the analysis, we noticed that this is a very great result. We have 4 different directions. They can interpret different ideologies and logic inside, and then it will provide us with very good for the intervention in the future. We also have this very important simple questions, and what we want to see is that the impact of the COVID-19 on vaccine attitudes, what kind of changes of the parent. So over 1/3 of the people, they pay attention to the vaccine itself, and over 40% say that the deterioration towards the safety of this. to the influenza vaccine, they have 1/3 the increase of attention to us, which means that COVID-19 is a kind of a lesson to be learned by the Chinese public towards the health, and then our confidence has lowered or declined in this regard. I asked some parents or the guardians, what about the trust? So we included the government, included the healthcare institutions, regulatory authorities, and the people said that they have trust to the vaccines and the regulatory, but they do not have a trust towards the manufacturers. So you can see that is related to the efficacy and the safety. That is a great challenge. One more question is that we ask these parents, what kind of the group that you are most reliable? I think that they will focus on the CDC, and it is not the truth, as a matter of fact. They will trust the clinical doctors. So you can see that the clinical doctors has a right to say. So in China, public health, this is the unique systems, and it is separated from the healthcare sector. So you can see that it is not unfriendly attitude from the clinical doctors. So you can see that misinformation among or lingering around, and we have this kind of the demonstration or pilot. I think that we can improve in this way to improve that as a confidence towards the clinical doctors. So we also asked the 2024 on April, what about the willingness of the vaccination or planning for vaccination is at 44% of the people. They have the plan for the vaccination, and and about 26% they do not have. So you can see today we will have very good level of vaccination this year. We are curious about another question is that for the pet vaccine hesitancy, whether this kind of so for the rabies, this kind of the vaccine, this kind of the parent are also share the suspicion of this efficacy and safety. So you can see that this is a spillover effect. Once have some misinformation related to that vaccine, and that will cause a lot of the damage. So this is one of the Denmark statistics and the spillover effects. And once the decline of the vaccination and will cause the rise of the various infections. So this is not interesting things. Is the current status. Now this is intervention strategies and a practice. I will share with you the interventions. This is what we've done in terms of the interventions. As a matter of fact, we have a lot of strategies, and that is the purpose of these strategies in improve the ratio for the vaccinations. And in China, we focus on the science and education, and also we have future healthcare workers and also economic incentives, or home visits. This is kind of the strategies in China. So HPV. One of the girl paid 600 yuan, and they can get a whole set of HPV. So you can see that is kind of incentives to also the education towards the medical students. I am the professors and the universities. So you can see that the training for the non-professionals is also really important, and also the intervention with some staff members. And we have published a lot of scientific books. This is kind of the education book. However, for this one, Zhang Wenfeng wrote the prologue of this. We mentioned that IPD he said that a virus infectious diseases. I think that this is a kind of the advancing Chinese medical. This is a kind. So it is no use to write the more terminologies to the general public. So I think that this is really good. The prologue by the academician. This is one of the investigation in recent years. In recent years, we discovered that the clinical doctors, especially, they have a great recommendation towards the female students or to the families than that of the other groups. So you can see the clinical doctors are very good. According to the investigations of the 1,000 TCM and the other Western medicines, you can see that in China, the lower confidence in the flu vaccines and more resistance to accepting the recommendation. So this is kind of the phenomenon in China. So in our universities, we face a lot of challenges each day. And so you can see that the vaccine education is really important for the research and the practice, and why the vaccination staff's knowledge of the vaccinology is inconsistent. And so we need to publish a lot of books like this. And so, Zhong Nanshan, he is also very famous, and he also do. We also record a lot of the video, and that is free. So we also conducted about the previous two, the Vaccine Science Education Committee. This is the international meeting. So for the vaccine hesitancy, that is really complicated phenomenon. That is the interdisciplinary subject. So I think that is really important work, and we should stick in. So our job at the present is the supervision, and the second is intervention. So intervention is really difficult to do, and you can see that at five cities we conducted the first batch of the surveillance for this year. We just collaborated with some of the doctors in a very famous hospitals, and during we also incorporate with the college students in this way to have a collaboration. And the vaccines at the present are related to the flu, influenza vaccines, and also the other needed vaccine and necessary for us. So this is the end of my report, and the vaccine. So this is a kind of the Chinese characteristics. This is kind of the intervention. So I just quote from one of the Second World War, the Churchill. They said a vaccine hesitancy, not at the beginning, not at the end, but it is the beginning. Thank you.
Not only important, but also very interesting and very well presented. I've always thought, since being here, that vaccine hesitancy, as defined oftentimes in the U.S. or in Europe, really is fundamentally different in here. And so you can see it in different behaviors. And I think your scientific approach and sociological approach and practical approach was really spectacular. So I'm glad that you're publishing and doing research on this topic. So anyway, congratulations for a very nice talk. So our next presenter is Dr. Zhang Juan, and she's with the professor in the School of Population Medicine and Public Health at Peking Union Medical College and also at China Academy of Sciences. She has a really wonderful working experience. She's worked with the National Health Commission, with China CDC, with the UN agencies, in academics, of course, and also in the pharmaceutical industry briefly. She has a PhD in health behavior from Indiana University in the US. I know that she's also a very strong bicycle rider. She's a very good cyclist. And we get to hear from her all about a cluster randomized controlled trial and quality improvement program in the school-based influenza vaccination program in Beijing. Let us welcome Dr. Zhang.
For your very inspiring, hilarious introductions. I really look forward to ride with you for another time. 我跟 Lance 先生是骑友，骑自行车的骑，所以
I wrote with Lance and
sorry, but as requested by the organizer, my slides are in English, so.
Dear colleagues, dear experts, good morning. It's my great honor to be here and share with you my research results. And I'm specialized in chronic disease research. Actually, 8 years ago, I was lucky that I was specialized in medical affairs and policy advocacy in Sanofi. And I have some experiences in the influenza vaccination, and also as a professional in public health, the key is to resolve problems, not only to describe and pinpoint the problems. I think that I feel the great sense of responsibility to do some intervention research. And previously, Professor Fu mentioned that it's very hard to conduct intervention-related research. I am very lucky to be sponsored to do the influenza-related research. There's a lot of reasons because influenza is very special. Every year, we need to vaccinate influenza, and also starting from September, the influenza vaccination program will be initiated, while the vaccination program will be completed before the end of October. So intervention is relatively short, and also it's easy to do the influenza vaccine-related study, and that's why we had such a research. As you are experts in influenza vaccination, I will not tell the evidences of the effectiveness of vaccination, in particular in schools. In Beijing, in 2008, when we were the hosts of the Beijing Olympic Games, actually starting from 2007, Beijing municipal government offered a free influenza vaccination to students in the primary and middle schools. Yet there's still a huge differences in the influenza vaccination rate, and it's related to implementation. Despite the free program, why there is such a big gap among different schools? Are there any good strategies to promote influenza vaccination rate in the schools? And that's the initial question for our study. And so in my talk, I want to brief you about our research. And this is the background. I think you are quite familiar with influenza, so I will not go to details. I just want to say that for the intervention study, most of the studies are mainly at the individual or interpersonal level, or such as the parental education. There are very limited research at the organizational level, and most of them are were in developed countries, while in our country, there are very limited research related to systematic intervention. So our research is an implementation research, and this is also a very fast-growing area because for implementation research, there are evidences, and our research aims to answer 4 questions. First, for the SLIFE program, as it has been implemented for many years, we want to identify barriers and the facilitators of its implementation. And also, we need to develop multifaceted strategies in response to the identified barriers. And thirdly, we want to evaluate the implementation of our strategies. Well, the fourth question is to evaluate the effectiveness of the multifaceted strategies in improving influenza vaccination uptake versus usual practice. So these are the four questions we aim to tackle. As I mentioned, that this is the implementation research. We have adopted the hybrid type 2 effectiveness implementation design. We mainly focus on two aspects. The first one is about effectiveness, and that is to say, we want to know if this approach has effectively enhanced the vaccination update. And then the second focus is to evaluate the implementation. Previous studies mainly focus on the effectiveness, but we don't know what's in the boxes. We don't know the why of the good performance or bad performance. So in implementation, we also need to identify the problems. And so in the future, when the other researchers want to do similar research, they could refer to our methods. And we have conducted the two-group parallel cluster randomized research. We have adopted hybrid methods. We have both quantitative and qualitative study. With the hybrid methods, we are able to collect information and comprehensively reflect the effectiveness of this implementation strategy. In the implementation research, there are a lot of theories. I mentioned a very important question in our research is to identify the barriers for the current practice. So we have adopted a very common framework. This is called CIFA. So for CIFA, we need to reflect the different elements based on the CIFA framework. We analyzed the facilitators and barriers. Just now, I also mentioned that we want to evaluate the effectiveness of the program. Therefore, also use the RE-AIM framework. To evaluate the effectiveness. And we want to know whether individuals are willing to accept these new methods. Well, lastly, we also want to know about its maintenance, because for a lot of research, after the funding was running out and or was terminated, the program also ended. But we want to know if this approach can be sustained. And also here you can that another theory is the MPT, normalization process theory, because it's a very great framework to evaluate whether the intervention can be integrated to the routine. And we want to know, can we do a better job? We don't want a brand new framework or methods in our daily practices. So we have also used MPT. Just I've already mentioned that this is a cluster randomized research, and we conduct research in schools, and we need to think about the criteria of the schools, we do know that 5 to 9-year-olds are the group at very high risks. Given the implementation, we picked up grade 2 and grade 3 because for the students at higher grades, it's not convenient for them to be part of the research because they may have heavier study workload. And also, we think grade 1 is not a good choice because they are quite new. So we have picked up the students of grade 2 and grade 3 with a parental electronic written informed consent and without any contraindication of the influenza. And based also on the previous vaccination rates, we pick up the specific schools. Shenzhen has done a great job in the influenza vaccination update, which was about 70%, while in Beijing, some had a very high rate. For instance, in Dongcheng district, a lot of schools, influenza vaccination rate is very, very high. And to better test the effectiveness of our strategy, we picked up the schools that have the vaccination rate lower than the district-wide mean for primary schools. And we also picked at the 2019 to 2020 season because actually before the pandemic, they have also used the data, used the influenza vaccination as a very important tool to prevent diseases. And we have altogether picked up 20 primary schools, and we adopted the blinding methods, 10 for intervention, 10 for control. And for control, it's not the pure control, it's just the team with usual practice, because we already mentioned that starting from 2007, Beijing already adopted the SLIV. So for the intervention group, we have adopted the multifaceted E/SLIVE strategies. So here, I just want to share with you how we establish these strategies. Just now, we mentioned there are some current facilitators and barriers. And we mentioned that the current facilitators and barriers and we have identified some facilitators and barriers. And so here you can see that we have a website. And so here we have a website, sorry. So here you can see we have a website where we can select the data, and then we got to identify the facilitators and the barriers. And so here you can see that this is very important. And for the barriers, there are a lot of relevant questions, and we think it's a very common issue. And that's why we mentioned in our strategy, we need to coordinate the different departments so as to facilitate their vaccination. Another one is at the school level. It involves the headmaster, and also the school teachers, school doctors, and they are very important factors. And Professor Fu also mentioned that the parents are very critical for the vaccination decision of children. So to educate parents is also very important. So you can see that we have adopted different strategies from the system level, school level, and the parental level. And here you can see some specific interventions we have done. In the interest of time, I will not go to details. Here you can see we already published the relevant paper. And if you are interested, feel free to refer to it. And I believe that the organizer will also share my slides with you. So feel free to get to know more details after my presentation. In the interest of time, I will just briefly show you our multi-faceted strategies. And for the different level of strategies, we have organized the different activities. For instance, we want to evaluate the outcomes of implementations. And so here you can see that for the vaccine, for the influenza and for other relevant diseases, we have conducted follow-up visits at 8 months. And here you can see that with a questionnaire, interview, and also different dimension of data collection, we got to know about its implementation. And this is the flow diagram of the overall research. I just mentioned that we have altogether involved 20 schools, 10 for control and 10 for intervention. So here you can see that when we conducted our research, it was during the COVID-19 period. And we encountered a very big challenge. A lot of schools in Beijing shut down, and one school was shut down in Beijing for intervention. And actually, this school has done a great job in intervention. I mentioned we collected a lot of data about intervention, but for the last minute, the school was shut down and not able to provide vaccination, while 2 schools of control were shut down. So we only have about 18 schools, 17 schools that have completed the whole process of the intervention. And I also want to mention that actually we mentioned we collected the data from the school, from the parents, and so we collected data from 2 dimensions. One is from the parent perspective, another is from the school doctor. Besides, we also collected information of vaccine and hesitancy, and we have also localized a questionnaire of vaccine hesitancy. This information was collected from the parents. In the interest of time, I'm not able to share with you some features of the schools in our research. I think that our research very valuable in terms of the facilitate in certain information. For instance, we found that the vaccination update increased, and maybe not dramatically yet. We can do in-depth analysis of the facilitators and the barriers, and it's very useful for the other researchers in the future. Generally speaking, the schools think that our and actually on the network open of JAMA, the paper was already published, and for the implementation results, we were also going to release it in another journal. In the interest of time, I have just share with you very brief information. So that's all for my sharing. So sorry, I have not managed my time very well. Thank you.
Wonderful study. I encourage everybody to read the JAMA Network open article in detail. I think that this use of implementation science is extremely important in immunization systems and helping to raise vaccination coverage. Using science to raise coverage as an outcome, I think, is great. So there's in WHO, there's an advisory group to SAGE called IVORAC, and it's an implementation advisory group, and I think that Professor Zhang would be a great member at that advisory group. Let's thank her for such a nice presentation. So our next presenter is Dr. Xu Jinghao. He's the Deputy General Manager of Meituan Medicine, Head of Innovation, the Innovation and Business Department, and he has Internet product development experience for over 15 years, and he has a special interest in epidemiology, which will come in very handy today in his presentation on the epidemic, disease trends, and signaling insights in the age of big data. Let us welcome Professor Xu.
Distinguished guests, ladies and gentlemen, I am the Deputy General Manager of Meituan. So I'd like to share with you challenges and innovations of online healthcare and managing respiratory infections outside hospital. So I also heard that we are the only one being invited as the enterprises. So as a matter of fact, I'd like to introduce to you the introduction about our company, but this is really familiar to you. And we have noticed that a lot of yellow packages of our logo, of our brand. So I think that you are the users of our company. And so given the time is short, I will not introduce the detailed introduction, but I give you the statistic is that the connections between our group and to this meeting. So in 2023, the patients by the 1.2 billions of the after-Mivir, and you can see that this is the this is the 12 million. So this we also have OTC, such as the fever and the cough, and this kind of the statistics that over 100 million. So as a listed company, the Meituan has some disclosure of the data, and it is different from the previous speakers is that not so the academic. So some of the statistics I cannot provide to you say in details, but if you're not interested into the academic communications, I can share with you. So as a matter of fact, I want to, in this occasion, what we try to answer the three serious questions. The first is how to predict a daily tide of millions of the patients, such as the influenzas and respiratory diseases. And the second is that it improves the professionalism of at-home healthcare. And the third one is that how to integrate with the current medical. So the first is that how to predict a daily tide of the millions of the patients. Before to answer this question, I'd like to share with you the background. This is why Meituan do that. The major business for us is focus on the Meituan Buy, that is to within 3 minutes to provide with the patients and home deliveries of this medicines, and related respiratory diseases is a kind of a great urgently needed, especially for the high risk or the high incidence of the diseases, and that the daily necessity is daily demand is higher, especially for this season. For the supply chain and the infrastructure, that is a very big challenges for us. In 2023, on March, during this influenza and in major Oscar is urgently needed and out of stock at that time. So from the perspective of the consumptions, we can only in line with the requirement of the 40% of the patients. So if we can provide adequate in the drugs in the 3,000 counties and regions in China, they can get the first hand of the diseases, and even that the high incidence time of this pandemic, and they can. This is a kind of the supply chain support. So we have this kind of the infection trends research. So what we use inside our research is a statistic from the online procurement. We have the two statistics to compare with you. So gray is that we got from the CDC. That is statistics from the channels of the respiratory disease, and the yellow line is related to the searching and ordering from the online consumers. So you can see that the statistics of these two. We discovered that the statistic of the Meituan can be used. So the fast is one of our characteristics. We noticed that the high incidence of the diseases and the very quick response to. The second is that, as we all know, that in a high incidence rate of the diseases start from the inside of the hospital. So the limited the capabilities or functions inside of the hospital. So you can see that some of the limited resources of the medical resources, and we can get the accurate information. So you can see that the internet is very no limitations, and you can see that the higher peak than that of the statistics from the inside of the hospital. So that is more accurate information from the community. So that is the relations of the non-infectious statistics and infectious statistics. That is the 20 to 30 times in that of inside the hospital. So that is a more accurate requirement or the demand by the consumers. So that is the 10, 20 to 30 times. However, I noticed that the reasons of the disclosure, I just delete one of the statistics. That is the statistics from the December 2022, because that is the important, is a sensitive period. So we noticed that at that period of time, the people a lot over panic because they witnessed that the December of the 2022. So you can see this is the great the panic memory inside these patients. So this is overreactions. We just, in accordance with this requirement, we just modify the calculations or algorithms of our statistics. So often, and then we have a more accurate curve of this. So we also have another advantages of the May 20 is that from the perspective of the CDC, and for example, a hospital can cover about over surrounding 10 kilometers, but for Meituan group, we know that even the certain unit or certain community or district of the, or even which building, so that is the higher accuracy of the position of the patients, and we can how can we predict the future trend of the infections. We just based on LSTM model. So that is at very first beginning of the incidence of the diseases, we will notice that as a surging increase of the symptoms, and then entered into the second phase, entered into the severe damage. So OTC order increase, especially for the antibodies, and also severe. The consumption will greatly increase. And the third phase is that of the reduce of the symptoms, and the people will buy some body care product such as the vitamin C. In this, we'd have the very awesome auxiliary enzymes to have a quick recovery of the body, and this sort of the nutritional product. So you can see that we can have a very great trend monitoring of the past 7 days of these epidemiological studies, and then through these statistics we can evaluate this model. So this is what we've done in the 2023. Well, in addition, in 2024, as a matter of fact, in some of the cities, we do the epidemiological predictions. So, frankly speaking, at the present, we didn't perform well, but we noticed that the epidemiological transmission inside the cities are largely correlated with the transportation vehicles, especially for the long vacations such as the May Labor Day and National Day. A great transformation of the population, such as the ordering of the air ticket and the railway train, and taking taxis. And fortunately for Meituan Group, we have this understand these transportation features before this vacation, and we know the statistics of the future trend of the destinations. So the second is how to improve the professionalism. So we have a question inside our mind, is that why we just stay at home to buy the medicines rather than go to hospital? I can show you from these two, the interpretation from these two slides. The pictures that we've taken by October 2023 in one of the Beijing's children's hospital, and that is infectious diseases. That is the fever clinics. So you can see a lot of doctors noticed that inside this kind of environment, that is a more high incidence of this. I think that we can have we have 1 to 2 infections of these pathogens, and once they went to the hospital, and more infectious diseases are by the other virus. So you can see that this is got from the real statistics. It's even that is in a high incidence rate of the that will bring a lot of overlapping infections. So that is the reason why we say at home procurement of these drugs is really important. And then this is the testing professionalism, the direct to consumer PCR test. And then we provide these professionalisms. And today this is the major reason I came here. And the last July, so this is a quicker services. We have 3 advantages. Number 1 is that fast or swiftness is really important. The waiting 3 hours from the payment, and then once you received, that is a higher rate. Start from the. So this is a quick. So the second is that. The testament of this etiology. So we have such as pneumonia or the intestinal drugs, or some, or such as these other alpha traccular. This is a kind of the quantitative studies. So it is not the CT value. However, this is the real situation that we got. I mentioned about the sensitivity of the information disclosure, and I just give you some statistics from the related to the performance. So this is the 40% of this. That is the 4 out of 40 people. 4 out of 10 will. Have the pathogenic virus, and from our algorithm, we can infer from we inferred to get the 70% of the infectious diseases, and the patients themselves know when is the time to go to see the doctors. And then I can give you 2 indicators. Number 1 is that PCR. So I know that inside the professional standard is related to the autopsy and the sensitivity, but these 2 statistics is as we are suspicions of about this statistics, because after the adequate laboratories inside the real inside our oral cavity, we have a kind of enzyme, and then that will decline the DNA of the etiology. So ourselves, this is a real world study, a real time to proofread this accuracy. So finally, that is TMGS is a kind of the to provide the target-oriented testament. So this is a kind of the management towards the doctors and the clinicians. So you can see that the eyelines are also needed the intervention and the participation of the doctors. And so, as just now I mentioned, to large extent to replace the doctors, but from the perspective of the consumers, it is really difficult for the consumers to judge whether it is the good or bad doctors. So they have the simple understanding that the doctors from the top hospitals belongs to the very good doctors, but for the general public or the consumers and or users, we have our own target is that we have the 100% of a very excellent doctors inside our online, and this is all the doctors from the top hospitals, and we have 25% has come from the Fudan or the very excellent top 10 of the doctors in China. So this is what we have, and then it relates to the meditation sales and the distributions. And if you didn't experience these services, you can have a try. And then this is how to integrate with the current medical system. So I share with you the 4 cases, and together with one of the National Center for Respiratory Medicines, we have the very good collaborations with the Japan-China Friendship Hospital. This is the primary medical institution, so they have the expertise in the national respiratory centers and world real studies, and at the same time, so for the first time to provide, we can transfer them to the professional institutions. The second is that as a channel for the promotion. So this is the we collaborate with Roche Pharmaceuticals, and I think that online pharmaceutical is not only to sell some material product, but as a matter of fact, I can give you an example. To take the Baloxavir are sales. You know that in Xiaohongshu, one of the very famous social media in China, one of the sharing of the 5,000 people are like and collected by over 4,000 people as so, and also 320. So you can see that this is a great large of the amount of the influence, and that the patients can buy online through influenced by this Xiaohongshu. So you can see that this is a different from the traditional seeing a doctor, and even by the 2023 at just the beginning listed in the market of the Baloxavir in China. So Roche has collaborated. So apart from that listed company, we also have non-listed innovative drugs during the process of the new drugs research. And we have RSV collaborations. This is so, as we know that for this, it is really difficult. This is really easy to get the severe patients, but for the light or minor indications of RSV, this kind of the group is difficult because when they inside. So for these scenarios, through the 3-hour testament, we can have early detections of the type of infections, and that for the positive RSV patient, if over 100, we can cover all age groups and collect the information from the client, from the patients, and from their symptoms or the history and allergic history of the patients, and to single out. So the first one to educate is that we are expecting new products listed in the market in terms of the respiratory tract disease. And the second is that for the clinical trial of the mild symptoms, and this is not inside of the hospital. The third is that we can provide to promote in this regard with the non-commercial oriented methodologies. Now, this is a collaboration with the Hainan Tech as the centralized sequencing lab network. So in the future, in the field of the testament, we have more an accurate diagnosis, and together with one of the technological companies, and we collaborate. We have a great influence, so we can to promote. So for the Oxford. So this is a slogan of this company, is that to have at any time, at any place, to have this kind of decentralized nano pore sequencing, and within 3 hours to have this gene test. I think that this is kind of very good accumulation of the statistics. This is kind of the exploration of the methodologies that will provide the solutions and the contributions to the prevention of the infectious diseases. This is what I share with you. And also, lastly, is that to let the health accompany everyone. Thank you.
You could see how big data was incredibly important during the pandemic, and you can see it's getting better and better and will be very important and central, I think, to the next pandemic. We heard how big data can be used and be integrated into healthcare system and even home care. It's really fascinating and fabulous. So congratulations on a very nice presentation. So our final speaker is Hainan Lin. She's a graduate student, or a graduate from Shanxi Medical University, and she's an MPH student at the School of Population Medicine and Public Health in PUMC. She has a research interest in vaccine hesitancy and also vaccination and implementation. The title of her talk is Social and Behavioral Drivers of Clinical Recommendations for Influenza Vaccination Based on Behavioral and Social Driver Model. So let us welcome Ms. Tao.
And it's very honored to share our team's research findings with you on the World Influenza Conference. So, and my supervisor is Dr. Lu Zhaofeng, and today I will be presenting on topic about social and behavior drivers of clinician recommendation for influenza vaccination. And the importance of the influenza vaccination, we know that in preventing and controlling the influenza is undeniable. So, and the clinician's recommendation is also play a very important role in increasing vaccination rates. So our research is deeply analyzed the some influence factors about the clinician's recommendation for influenza vaccination. And my research will last 10 minutes and for 4 parts. The first part is background. So we know that there has several vaccine effectiveness of the influenza vaccine, such as prevent the infection and also reduce the severity of the disease and also the risk of the related hospitalizations, and especially for the key and high infection risk population, which is shown on the slides. So, but despite this part, we know that the influenza vaccination rate in our country it's a little bit low, such as we can see that on the the figure, we can see the total of the 2021 to 2022 influenza season, the vaccination rate is about 2.47%. And especially focus on for the high-risk population is also not high. But we have the several researches, we can find that the healthcare worker recommendation is very important. As mentioned, Dr. Lance and also Dr. Fu had mentioned a lot about this part, that the healthcare workers has a higher influence more than the public health workers, as you can see for the adults. And also for the elderly, we can see that the healthcare workers recommendation have attached about 74% among the elder populations. So based on these backgrounds, we want to figure out two main problems. The first one is, are the clinician willingness to recommend the flu vaccination, and also what the factors influence their recommendations. So for our study, we use a vaccination hesitate model to guide our theoretical part. This guide is called the BSD framework, and it conducts several parts. The main, we also have some localization in China for our study. So we conclude the thinking and feeling, social and process, and also practical issues this part. And for the details, it's about the vaccine confidence and also the social norms such as others' recommendation. And also for the practical issues, we conclude some service quality when they got vaccinated. So our research was conducted on the IQVIA's platform, which is us clinicians, users, and we conduct more than 2,000 clinicians, which is from secondary and territory hospitals in 29 provinces in China. And the main results, we found that the willingness of the different hospital departments to provide vaccine advice or prescriptions. And for the left side is about the vaccine-related advices. And we can see that for the highest willingness is about the pediatrics and also general practice, which we can find that their patients are mainly about like HPV vaccines or there have some children vaccines, which is the clinicians also very familiar for these patients willingness. And for the unwillingness is oncology. We found maybe it's about their patient's condition is not very well or other reasons. And we, based on the BSD model, we keep to find the reasons which is motivate the clinicians willing to recommend the vaccination. And we found that the clinician's personal accomplishment by improving the health level of the patients is the highest. So as in China, I thought maybe it's different from other culture. As Dr. Fu said, there has some hesitance. Vaccine hesitance is related to our culture, that some separate inspire is more than maybe the money or other go straight forward the awards. And also we figure out some unwillingness to the recommendation. We found that the clinician lacked the knowledge about vaccines still is the highest unwillingness to recommend the vaccination. And also we conclude other reasons, such as they worried about the patients have no money to pay for the vaccines, or they worried about some like commercial interests, like they will worry about these things to recommend to others to take the vaccines. So we want to keep going to figure out some reasons. So we conduct a mediating effect regression model to further analyze the reasons. And we found that the risk of the adverse reactions and also the vaccine effectiveness also act as mediating effects which will impact their tendency to recommend the vaccines. So finally, we found some incentives for clinicians to recommend the vaccination. And I thought that this is a very interesting fund because at the beginning and also for some literature reviews, we found the bonus maybe will help them to or inspire them to have the idea to recommend the vaccine to others. But we finally found that provide professional recognition can cover the incentiveness of more than 80% of clinicians. Such as like give them some like professional title or other some encourage. So based on our research, we have three main conclusions. And the first one is the clinicians have a high willingness to provide vaccine recommendations, and it includes both about provide the vaccine related provide the vaccine related and also the prescription. And for the second is like encourage clinicians to recommend the vaccination through the implementation of incentive measures is very important. And for the last is we know that BSD2 is a very important tool for the researchers to conduct some vaccine taste research. So provide some scientific data for the localization is also very helpful for the BSD2 because we know as before, we always use the 3-6 model or 7-6 model, but now we have the BSDs from WHO. So sometimes I thought provide the new updated things to this tool maybe will help other researchers to keep going some this areas research. So at the last, I will be very grateful for my supervisor, Dr. Lu Zhaofeng, for all the support, and also very grateful for my colleagues. And our research also based on the questionnaire platform is QVIA, and also I'm looking forward a lot of suggestions and comments about our research, which we can keep contact. And thanks so much. Thank you.
Thank you so much for your reporting. And we have also used the BSD model for the research of elderly. In the very beginning, it's mainly based on the COVID-19 vaccine. But our presenter also mentioned that it's also very useful for the localized research. I think that we need to also conduct some quantitative research. And we are very happy that this morning, as for the risk communication, we have finished all our agenda. Thank you so much for staying with us. And we are very happy that our speakers covered the vaccine hesitancy and also the big data technology applied in this area, as well as a very systematic report. We hope that our presentation will be very useful for you, for your work and for your future research. Thank you so much again.